Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Rania Hamza, Anesthesia Consultant. Today we are going to talk about anesthesia for laparoscopy. We are going to discuss the procedures done with laparoscopy, what's the benefits of laparoscopy over open surgery, what are the surgical requirements, the patient positioning, the effect of gas insufflation, the risk of trauma, the preoperative, the perioperative, the postoperative management, as well as some special considerations at the end of the procedure. Let's start with the procedures done with laparoscopy. Laparoscopic surgery is well established for a range of procedures, including cholecystectomy, hernia repair, appendectomy. It is increasingly used for more complex procedures, including the major colorectal resection, prostatectomy, and nephrectomy. The benefits of laparoscopy over laparotomy include reduced tissue, trauma, wound size, and postoperative pain, improved postoperative respiratory function, reduced postoperative EDS, earlier mobilization and shorter hospital stay, improved cosmetic results. What are the surgical requirements? Insufflation of gas, usually carbon dioxide, into the peritoneal cavity creates pneumoperitoneum and separates the abdominal wall from the viscera. The carbon dioxide is the most frequently used gas, being non-combustile, which allows the use of diathermy and laser, as well as it's colorless, it's non-toxic, and it's highly soluble. Carbon dioxide is insufflated at a rate of 4 to 6 liters per minute to a pressure of 10 to 15 millimeter mercury. The pneumoperitoneum is maintained by a constant gas flow of 200 to 400 milliliter per minute. Now let's discuss the patient positioning. The upper abdominal procedure requires the head up position. So you place the head up. This is called reverse Trendelenburg. In the lower abdominal procedures, you place the head down, which is the Trendelenburg position. Some left tilt is usual with the cholecystectomy. Patients placed with head down are at greater risk of reduction of the functional residual capacity, decrease or ventilation perfusion mismatch, atelectasis, and also the cephalad movement of the lungs and carina in relation to a fixed endotracheal tube increases the risk of endobronchial intubation. As for the patients placed head up, they are at increased risk of reduced blood pressure and cardiac output due to the decreased venous return. Those most at risk include the hypovolemic patient, the elderly, and the patients with pre-existing cardiovascular disease. Now let's discuss the effects of insufflation. The effects of insufflation, of the gas insufflation, can be either physiological or adverse effects. The physiological effects of the insufflation of the gas peritoneum, including respiratory effects, cardiovascular effects, gastrointestinal effects, and neurological effects. Whereas the adverse effects are vagal stimulation, sympathetic stimulation, acidosis, extraperitoneal insufflation, prolonged procedures effect, venous air embolism, and cardiac depression. Now let's start discussing these things. First, let's discuss the physiological effects of the gas insufflation. The physiological effects of pneumoperitoneum are, as for the respiratory effects, there is increased airway pressure and increased ventilation perfusion mismatch, decreased functional residual capacity, as well as decreased pulmonary compliance. As for the cardiovascular effects, you may find decrease in the venous return, increase in the systemic vascular resistance, plus or minus decrease in the cardiac output, as well as risk of arrhythmia. Gastrointestinal effect, you can find increased risk of regurgitation. Neurological effects, you can find plus or minus increased intracranial pressure and increased cerebral perfusion pressure. Now let's discuss the adverse effects. Stretching of the peritoneum may cause vagal stimulation, resulting in sinus bradycardia, nodal rhythm, and occasional asystole. Anticipate and treat with vagolytics like atropine and glycopyrrolate. Gas insufflation may result in sympathetic response, leading to hypertension and tachycardia. Carbon dioxide is readily absorbed from the peritoneum and may cause hypercapnia and acidosis. Extraperitoneal gas insufflation may occur through a misplaced stroker or insufflation needle via an anatomical defect, for example between the pleura and the peritoneum, or when gas under pressure within the abdomen dissects through the tissue planes. This may result in subcutaneous emphysema, pneumomediastinum, pneumopericardium, or pneumothorax. Passage of carbon dioxide from the abdomen can be anticipated in laparoscopic procedures around the diaphragm, for example, hiatus hernia repair. It happens when a communication is made between the abdomen and the chest. Pneumomediastinum and pneumothorax may occur, and the suggestive signs may include a rapidly increasing end-tidal CO2, rising airway pressures, and falling in the oxygen saturations. Evacuating the CO2 from the abdomen will often rapidly resolve the problem, and recommencing the surgery under reduced insufflation of CO2 would usually enable completion of the surgery. If there is significant cardiac or respiratory compromise, manage like a tension pneumothorax by needle decompression. Back to the effects, the adverse effects of the insufflation. If during the prolonged procedures with rising end-tidal CO2 break may be required. Also, venous gas embolism may rarely occur when gas is inadvertently insufflated directly into blood vessel. Physiological effects are less with carbon dioxide than air due to its greater plasma solubility. However, a significant embolism may be fatal. Signs of the significant venous gas embolism includes reduced end-tidal CO2, desaturation, arrhythmia, myocardial ischemia, hypotension, and elevated CVP. The last adverse effect is cardiovascular depression with a fall in cardiac output. In this situation, you have to treat with fluids, vasodilators, and inotropes. Then let's shift to the risk of trauma. Introduction of the trocars may cause damage to organs like the spleen, the bladder, the liver, the bowel, the stomach. Organ damage may not be always apparent at the time of the injury. Damage to blood vessels may result in massive hemorrhage, necessitating rapid conversion to an open procedure. Now let's start to talk anesthesia and check the preoperative management of such patients. Contraindications to laparoscopic surgery are relative. Risks are increased with ischemic heart disease, valvular heart disease, increased intracranial pressure, and hypovolemia. All patients scheduled must be considered at risk of conversion to an open procedure, and a plan for analgesia is discussed. Laparoscopic procedures are increasingly performed in the obese patients due to the improved post-operative recovery when compared to an open procedure. Premedication with H2 antagonist or PPIs if at risk of regurgitation, for example, obesity and hiatus hernia. Simple analgesics like paracetamol and nonsteroidals may be beneficial. As for the perioperative management, we are going to discuss some items like what is the safest way or method of anesthesia, avoid gastric distension, some consideration for the lower abdominal procedure, carbon dioxide level, hypoxia, nitrous oxide, analgesia, fluids, antiemetic, monitoring, and subcutaneous emphysema. First, let's discuss that. Let's emphasize the idea that general anesthesia with endotracheal intubation and muscle relaxant and controlled mechanical ventilation is considered the safest technique, as it protects against pulmonary aspiration and enables the control of PaCO2 and aids the surgical exposure. Avoid gastric distension during bag mask ventilation, which may increase the risk of gastric injury during the trocar insertion. For lower abdominal procedures, urinary catheter may be required to decompress the bladder and reduce the risk of injury. Systemic absorption of carbon dioxide and raised intra-abdominal pressure will require increased minute volume and result in high intrathoracic pressure. Aim for normocapnia, but beware of adverse effect of high intrathoracic pressure. Controlling end-tidal CO2 during prolonged procedures, especially in the obese and head down, can be difficult and may occasionally necessitate intermittent release of intraperitoneal gas or tolerance of a degree of hypercarbia. With high peak inspiratory pressure, check the position of end-tidal CO2. Try change to pressure control ventilation, i.e. ratio 1:1 and 5 centimeters water PEEP. When the patient is leveled out, remember to check the tidal volume or alter the ventilation mode or pressure. As for nitrous oxide, it is controversial due to the possible associations with bowel distension and increased PONV. As for analgesia, this is dictated by the procedure. Pain may be intense but short-lived, and short-acting opioids like fentanyl and alfentanyl may be effective for short procedures. Remifentanil infusion can be useful for longer procedures and may help counter the hemodynamic changes due to the pneumoperitoneum. Longer-acting opioids may be required for extensive laparoscopic operations. In extensive laparoscopic surgery, epidural analgesia or spinal plus-minus intrathecal opioid may be beneficial. As for the fluid management, avoid hypovolemia, as this exaggerates the deleterious CVS effects of laparoscopy. Give antiemetics because of high incidence of nausea and vomiting following the laparoscopic surgery. Give prophylactic antiemetic and prescribe post-operatively. As for monitoring, pay close attention to end-tidal CO2 and airway pressure. Invasive arterial blood pressure and CVP monitoring may be required for extensive procedures and for patients with cardiovascular or respiratory compromise. If hypoxia occurs, consider number 1, hypoventilation. You have to consider 4 things actually. You have to put them in mind: either hypoventilation or reduced cardiac output, or ventilation perfusion mismatch, or subcutaneous emphysema. You have to consider these 4 things. Let's discuss first the hypoventilation. Hypoventilation, it may be due to inadequate ventilation, due to pneumoperitoneum, head down position, etc., any other reason. Reduced cardiac output. It may be due to IVC compression, arrhythmia, hemorrhage, myocardial depression, venous gas embolism, extraperitoneal gas. Okay. As for the ventilation perfusion mismatch, it may be due to decreased or reduced functional residual capacity, atelectasis, endobronchial intubation, venous gas embolism, pulmonary aspiration, and rarely pneumothorax. As for subcutaneous emphysema, during the procedure should arouse suspicion. So you stop gas insufflation immediately and check for the source of the problem. Now we reach the post-operative management. At the end of the operation, encourage the surgeon to expel as much intraperitoneal gas as possible to reduce the post-operative pain. Intraperitoneal local anesthetic infiltration of port sites may reduce the post-operative analgesic requirement. 20 to 30 ml of 0.25 bupivacaine on the gallbladder bed may reduce the post-operative analgesic requirements for laparoscopic cholecystectomy. The pain varies and is often worse in the first few hours. Shoulder tip pain due to diaphragmatic irritation may be troublesome, but is usually short-lived. Significant pain extending beyond the first day raises the possibility of intra-abdominal complications. Prescribe regular paracetamol, non-steroidals with opioid as required for more extensive procedures. Consider also the post-operative antiemetics. There are some special considerations that we have to put in mind. First, the laryngeal mask. Some anesthetists use an LMA for laparoscopic procedures. This is an individual choice, but should be avoided if the patient has history of reflux, obesity, or with an anticipated difficult or prolonged procedure, especially in the head low or the head down position, with an inexperienced surgeon. An LMA may be useful for short procedures, for example laparoscopic sterilization, provided that the anesthetist is experienced and patient selection is appropriate. Third generation supraglottic airway devices, for example the ProSeal, Supreme, iGel, etc., may be advantageous because of their gastric drain tubes. Regional anesthesia is not generally used as the sole anesthetic technique because of the high level of block required to cover the pneumoperitoneum. And that's it. We conclude our session for today, anesthesia for laparoscopic procedure. Thank you for listening. Hope you benefited. Till we meet next time, this is Dr. Rania Hamza, Anesthesia Consultant. Assalamu alaikum.